This week on the BackTable podcast.
And if you're always making a decision saying, well, I'm not going to use IVL because it's more expensive, or I am going to use it because it's covered, that's not the right way to look at it. Again, the economics, what's the economics of someone an hour on the table? What's an economics of a perforation? What's the economics of someone being in the ICU for a week? What's the economics of death? So these are all things I bring up when people tell me it's more expensive. I think as long as you're using your data, your angiographic data, your imaging data, you're meeting your endpoints, then I think it's really hard to argue. Now, clearly, if you're pulling out all these devices when there's no calcium or very minimal calcium, then that's obvious. But if this is data-driven, I think there's a lot of ways to skin this cat.
All right. Good morning, Alex. We're super excited to have you in our next series of BackTable podcasts, specifically focused on cardiology. My name is Hady Lichaa. I'm an interventional cardiovascular specialist at Ascension St. Thomas Heart in Murfreesboro and Nashville, Tennessee. And I have the huge pleasure of speaking with my good friend, Dr. Alex Truesdell at Virginia Heart with Inova Heart and Vascular. And he is so well known for his extreme expertise in CTO and complex cases, and has taught us a lot of tricks. And we're going to be talking about all tortuosity today. Good morning, Alex.
Good morning, Hady. Thanks for having me.
I'd love to get the audience to know you if they haven't met you yet. Can you tell us a little bit about you and your practice?
Sure. I guess the biggest background to start is interventional cardiologist. Obviously, I trained in Brown in Rhode Island. I like to say I'm a chronologically older middle career interventionalist because I took 10 gap years, for lack of a better term, in the Army. And I've been here in Northern Virginia now 10 years and do a lot of complex PCI, CTO, a lot of mechanical circulatory support, cardiogenic shock, and then I also work in the cardiac intensive care unit here. And so that's probably a quick snapshot.
Fantastic. So we thought approaching the topic of tortuosity kind of starts getting to the heart. And of course, now with radial being our first approach, let's kind of approach the subclavian innominate tortuosity and see what Alex does in his daily practice. We're talking extreme tortuosity, not the, glide wire crossing and then guide crossing. The cases where this strategy is not working. What do you do next?
Yeah, so if I may, I'm actually going to even rewind from that because I think, and I've evolved over the years. I think when I'm thinking about how do I approach tortuosity, I think particularly for complex cases, I think about how do I approach the whole case? And the big picture is you want to minimize ischemic time. And you want to minimize time on the table. Our patients are a lot older, they're a lot sicker, lesions are more complex. And so all of that kind of informs how I think through planning and preparation and execution. And then also, I think there's a lot to be said about knowing yourself. So when we're going to talk about my algorithms and what I do, that may be different for someone else. And you have to kind of be honest with yourself. So to start, tortuosity is, are there prior CT scans? Are there prior duplex studies? Are there prior angiograms? So what do we know about the patient? Because if you already have a heads up about tortuosity or anatomic difficulty on one side versus the other, perhaps you choose left radial over right radial. Perhaps you choose femoral over radial. So if you have that data available to you, I think that's very important. And it's kind of a fail not to spend a little bit time identifying that and seeing how that can influence things. So once it's already happening, I think, I think your question is, what do you do once you're, encountering tortuosity? So for most people, I'm going to start radial, although if it's a very, very complex procedure, left main bifurcation, I, may start femoral with 7 or 8 French and a long sheath, but let's say starting radial. So if I first encounter tortuosity, I always tell the techs, if you find any resistance, stop. You find resistance, I come down and I fluoro, and that's usually going to be right around the elbow, right? You're going to hit a radial loop. So I'll stop. I'll go very gently with, usually it's the 0.35-inch wire. If that's not going, I'm going to stop right away, and my go-to is to pivot immediately to a coronary workhorse wire. And I'll do that under direct fluoroscopy and watch the wire. If it sails, fine. If it navigates a radial loop, fine, but at least I know. And then I'll watch it go up to the shoulder, and then I'll follow through whether, again, if this is a diagnostic, with a diagnostic catheter, whether it's a known PCI with a guide. If somebody is low BMI, a woman, and I've found tortuosity, I'll start with 4 French. If it's a guide, then I know, hey, I'm probably going to have to go right up with balloon-assisted tracking, and I'll do that right from the get-go. I think I've learned over time, instead of trying A, B, C, D, E, I've learned, I already know what's going to happen, and I can sort of see the future, so I'll skip to E. So I have that coronary wire up, try and slip the guide over it. If there's any resistance, stop, and immediately moving to balloon-assisted tracking, typically, 20 millimeter length compliant balloon. And again, I will visualize that under fluoro going up. So now I'm up to the shoulder. Now, if you have tortuosity there, again, either the coronary wire with a torque device to, navigate the tortuosity, or a stiff angled glide wire. And again, watching to make sure it goes where you want and not upstairs. And so I think that's the value of fluoroscopy, and then getting it down into the, aortic root. And I will say that's my algorithm. I feel very comfortable with radial. And then if I feel like there's less support, I'll put a stiff Amplatz wire in the guide, and I will leave that in the guide to allow one-to-one torqueability. And I will perform angiography with that wire in the guide. Obviously, 5 centimeters back from the distal tip. But that may be different for someone else. So I see someone else will maybe switch to femoral, switch to left radial. So I think that's part of knowing yourself. And I think the key thing is, we're going to talk about algorithms, but everyone has to come up with their own algorithm and figure what is best for them. So that's a fast algorithm for me, because I already know boom, 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 what I'm going to do. My team knows, we have the equipment on the shelf. Someone else, it might be faster and safer to switch to femoral. I don't know.
Yeah, no, that's a great kind of run through the major steps. A couple of questions. So first of all, in terms of your disclosures, just tell us what relationships you have with companies, because we're going to be talking about a wide range of equipment here.
Yeah. So in the past couple years, I've had either a speaking or consulting fees from Abiomed, Getinge, Shockwave, and Zoll. And I will also freely disclose, there is no company that makes everything. There is no company that has all the equipment,
agree.
And much of the equipment is probably the same. So I go with whatever the contracts go, and I haven't, as much as we'd all like to blame it on a piece of equipment, the hospital makes me switch equipment all the time, and I have to look in the mirror if something's not happening. So that's probably the best equipment and company disclosure I can give.
So perfect. Yeah, so for the audience, we're going to be mentioning specific tools that you use in your daily practice. So in terms of a super slick 035 wire to get through tortuosity, what's your favorite?
So honestly, I just used a standard J wire. And then if that doesn't work, as I mentioned, I'll use a coronary wire and or, it depends on the situation, a stiff angled glide wire.
Coronary wire is stiff enough to get you through support-wise?
That's usually the test to kind of see tortuosity, because it's really, really safe. It's fine. It's safe. So if there's a lot of loops, a lot of tortuosity, that's where I'll start with. And then I'll switch back to a regular 035 wire. Again, I think a stiff Amplatz or similar type of wire will be, if I know that there's so much, radial, brachial, subclavian, aortic tortuosity, that I'm just not going to get any torqueability, and I want one-to-one torqueability to get to where I'm going, I'll just jump right towards that, because now I know I have a stiff rail that I can do anything.
And I love the tip that you mentioned about keeping the super stiff wire in the guide with a tight hemostatic valve, just to make sure the wire doesn't move, or if you're holding it in the back. Because so let's say you remove the stiff wire, now you're putting your workhorse wire, the shape of the guide is going to change now, and sometimes you disengage. So putting an 014 workhorse wire that you're going to start with next to the 035 Amplatz, wiring the vessel, then removing the super stiff Amplatz is, I think, super helpful now that you have access to the vessel, and even if you disengage, you can re-engage easily.
And again, I'll just reinforce that this is the value of having your own personal protocol. Because if every time you encounter an obstacle, you have to stop and pause and think, and oh my gosh, what do I do? And then next obstacle, pause, versus, you come to a branch point, okay, boom. Come to a branch point, boom, come to a branch point. It's not just about your hospital wants you to move through the cases, but again, limiting time on the table for older, sicker patients. People start getting fidgety because they've been on the table a long time. That's a safety issue, because if they move, that's hazardous to them. And, you get fatigued. All of these things create patient hazards, and many of them can be prevented by prior preparation, thought, planning, equipment preparation, strategy preparation, a little prep with looking at prior imaging, as I mentioned as well.
Fantastic. Now let's move on to the iliac. You decided you're going to go 8 French femoral access, and you have a nasty zigzaggy common iliac artery. What are you going to do?
Yeah, so pretty similar. You start with a J wire, and again, the key is, as you know, if you meet resistance, stop, because you can get through anything. It's just whether you're going to shred the vessel or not, dissect. So if you meet resistance, stop. So I guess I'll even rewind. So access should be ultrasound guided, whether radial or femoral, period. I don't think that's debatable. Micropuncture, and watch the micropuncture wire go up so it's not going in little side branches and going to cause RP bleeds. I think that will give you a heads up, because the micropuncture wire is going to show you if there's some tortuosity. It's long enough for that purpose. And then doing a selective femoral angiography through the micropuncture sheath, and I only use stiff micropuncture kits. So then you've already got a lot of information. So now I know up front, okay, I'll still usually go for the 035 regular J-wire, but if I hit any resistance and I already know there's tortuosity, I'm going to stop right away. And again, pivot to a stiff angled glide wire for me with a torque device on that to engage very carefully and slowly, and again, under direct fluoroscopy.
Excellent. So now in terms of coronary tortuosity, we got to the heart, we have our long sheath. And by the way, have you been using the radial to peripheral long radial sheaths for this matter once you get through?
For you in the radial?
Radio and subclavian tortuosity, do you put a long sheath in?
No, so I've kind of transitioned over the past couple of years out of vascular. I wrote a paper about radial to peripheral before all this equipment was available. It was 2015, 2016. And so I did that for a while, but I don't really do peripheral other than stuff I need to do to be safe, get myself out of trouble, be good. So I don't really use that. And if I'm doing it for coronary, I use the same short radial sheath, and I haven't really found any need if you're doing all the other things, because once you get the guide there, and I find some people who are maybe not comfortable, that don't have a lot of peripheral vascular skills, don't have that training, don't have that background, that experience, can get themselves into trouble with those long sheaths, either entrapment, vessel injury, a number of things. So again, it goes back to, again, you got to know yourself, but I personally don't use it at all for that purpose. And even when I do dry closure, I just do a bare balloon. In the rare instances, I do dry closure. So even then, I don't use a long sheath.
You mean the dry closure technique where you put a balloon through the ipsilateral sheath?
So if I'm doing if I'm removing a mechanical circulatory support device and I want to do dry closure, and I'm taking it out from the femoral, I will take the balloon, an 8 millimeter by 40 millimeter typically balloon, to occlude the iliac, but I will do that from radial access, and I will just come over the wire without a long sheath, because now you have rapid exchange balloons, again, within that R2P portfolio that are well suited to that purpose.
So now we got to the heart. When you say tortuosity, I mean, obviously, all of us, we look at a case, we'll say, okay, this is tortuous, but do you have a specific definition for severe coronary tortuosity? Is it 45-degree angle times 2, 90-degree times 2? What's in your mind?
Yeah, it's funny. It probably varies. I guess I'm going to, make a joke. It's kind of like that Supreme Court quote about pornography. You know it when you see it, even if we can't define it. But I think it depends. So because it's a mix of, is it a 45, is it 90? Are there 3 of those angles? Is it a switchback? Is there also calcium? And then also whatever you're going to do, what other vessels are going to be jeopardized? So if I'm thinking there's a lot of calcium, there's a lot of tortuosity, and it's more distal, and I'm thinking ahead about equipment I have to deliver, then let's say it's the circumflex. am I going to be jeopardizing the LAD or the left main or the ramus in doing that? So I think all of those things factor in, but I think probably calcium, how far distal, and it's not necessarily the tortuosity, but what is the combination of how many angles and calcium and how distal, so that, that's going to really make the delivery issues either difficult or not difficult.
Great. So let's go through each vessel separately. So LAD, you have a mid LAD that's extremely tortuous. What's your favorite guide for that?
So again, this sort of goes back to, your own security blanket. I like the EBU guides.
That's right. That's what we want to know.
So yeah. I use EBU guides. I know other people use, XBs. So that's my go-to guide. Whether that's better or worse, I don't know, but it's better for me. It's a little stiffer, but I have much more of a aggressive approach to intervention, and I like that guide. I also know what it does. It maintains its shape, and that's what I'm accustomed to. So my eyes, my brain, and my hands know what it's going to do. So for LAD, I'm using the EBU guide literally 99% of the time.
Let's say you had engaged with a JL35 for your diagnostic, or Tiger or Jackie. Now you want to intervene and you have a normal size aorta. What EBU would you pick?
Yeah, so I'm most of my cases, if I don't have prior anatomic information, either from echo, from CT, or if there wasn't information derived from the diagnostic angiography showing that it was a large root, then it's going to be usually an EBU 3.5. I think if it's for the CTOs or more complex interventions, and if it's then I may favor a 3.75 to get it in a little bit deeper. And again, if it's left main, I'm thinking 7 French or potentially, 8 French even. But otherwise, everything from the get-go is going to be 6 French. So usually I'm going to say 6 French EBU 3.5, sometimes 6 French EBU 3.75 guide.
Absolutely. I practice the same, and I noticed over the years by moving to the radial on the complexity side, I've added 0.25 on the radial to kind of compensate for that slight lack of support from when compared to femoral. And those guides are also what I like about the EBUs is the 0.01 inch larger, which allows you to sometimes put a wire and an IVUS and slightly more space for little things, especially on the 7 French side. So
and that's critically important, because I can't tell if all the companies intentionally make math hard. And I had a commander in the Army that always said, never do math in public, right? So you're trying to figure out what's compatible, what's not. And sometimes that can be trickier. It's easier in the coronary space than it is in the peripheral, but a little bit of extra interlumen diameter from a guide. But then you start thinking about guide extensions, multiple equipment. Some of the stents, like the Megatron, the larger size stents, don't fit through every guide extension. And so some of this is you got to think through in advance. Some of it is trial and error, but in your brain sort of know what fits, and that's going to influence guide size, French size, etc. From the beginning, or it might even equipment type and company type also.
Great. Now, left circ, you have a left circ that's taking rise at an obtuse angle or even retrograde circ with tortuous elements. Are you changing your guide?
No, again, I'm probably, based on the aortic root size, going to stick with an EBU 3.5, or again, like I said, 3.75. I use guide extensions like candy. So, that if I see that, I already know I'm going to do a guide extension. And I understand there's a cost with equipment, but there's also a cost if I spend an hour less in the cath lab. And there's not only a throughput cost savings, there's also a savings of complications and harm to the patient. Again, ischemic time on table, the operator fatigue, all of those things. So I very quickly, and some things I'll very immediately put the guide in, even before I take a picture. I'm running the guide extension through that with no picture. Then I'm running a microcatheter through that with no picture, have that all of the tip even before I introduce a wire based on the diagnostic angiogram. So I've sort of learned things when I know the job's going to be tough. I have all that stuff, set up in advance. So typically wouldn't change the guide other than maybe the French size, but I wouldn't change 3.5 to 3.75 typically that much from, LAD, CERC, but I am thinking about the different components.
And I love the fact that you go in all guns blazing. When you see that anatomy, you don't go step by step. You go straight to in your algorithm to E. So we call them the triple threat in my lab, the guide extension, microcatheter. So they're all kind of going in at the same time from the beginning, because you're definitely expecting a lot of technical difficulties. So that's fantastic. Do you like guide extensions with trapping balloons from the get-go or not?
Yeah, again, I think that depends. So in our lab, we're typically using Guidezilla for guide extension. We recently added liquid to the shelf, which is really cool because, again, it has extra inner diameter. So that gives you a lot more options when you're in 7/8 French. And so in the past, I would also use just a regular balloon as a trapping balloon. I use the trap liner a lot now, I think, which is fantastic. So we use that for all of our CTOs. And so I've definitely really been over the past couple of years incorporating that more into the regular non-CTO interventions too, because I'm always using short wires anyhow, and it just helps with equipment exchanges. And again, thinking through, okay, if I look at a lesion, I say, boy, lots of tortuosity, multiple switchbacks, angles, calcium. I already know there's very little chance this is going to be easy, and I can either make this, smooth and challenging, or really hard and problematic. And there's not really other, options.
Right. Yeah, so the Guidezilla is phenomenal. Obviously, this polymer jacket gets you through a lot of difficult places. But if, let's say, you have a Teleflex on your shelf, would you pick the Coast or the regular? Each one of them has pros and cons, but in tortuous anatomy, would you pick the Coast?
Yeah, so I can't really speak to equipment I haven't used. So again, but part of this goes back to me is I said, it's the carpenter that blames their tools versus their skills and training. So we've had a lot of switches. When we had Guideliner, that worked fine. When we switched to Guidezilla, that worked fine. When we have trap liner, that works fine. Liquid, I think, provides an additional advantage just because it's bigger. But to me, it's about the whole package. So imaging to decide, do you need lesion preparation for calcium modification, coming in with all of those steps about how you're going to get support. And that's probably more important to me than the individual company devices, because probably most of them, the engineers at all those companies are pretty darn good. So they're probably, in my opinion, pretty similar, and there may be some small nuances. But again, a lot of us are tied to contracting, and which is fine. And so I haven't used those other devices, but all the ones I haven't noticed that, they all get the job done, I guess is what I can say.
And just a little note on liquid, I haven't had personally used it. Do you compromise on the actual support of the guide extension by making it larger, or the braiding kind of compensates for that? Do you feel like it's harder to deliver, or does it kink easier?
Yeah, I really haven't noticed, any difference in terms of that. So then the only thing, I've noticed is that I have more room, more room to operate, within. And then again, it comes with you use a specialty trap balloon, so that's just something you just fiddle with to figure out how to use it. But you can use just a regular balloon for that purpose if you want. It's just less reusable.
And I've heard from colleagues also, depending on contracts, with Telescope from Medtronic also does a good job in there. So now moving on from a guide extension, before we get to the delivery of the guide extension, tell us about your wire choices when you have a super tortuous anatomy.
Yeah, so I'd probably, most of the time I'm just starting with a workhorse wire. But if I see, hey, there's a lot of tortuosity, subtotal occlusions, and calcium, then my immediate go-to is sort of my algorithm is usually, we're again, contractually, Marvel is my typical workhorse. And then my next is Xi'an Black for tortuosity, or again for those subtotal occlusions, and it's great for those very straightforward, simple CTOs too. And Mongo wire also, I think, also has similar great properties. So those three are like 90%. What's that?
Why do you like the Xi'an Black?
Yeah, I think just hydrophilic, and it really just finds those channels and moves through easily. It's very maneuverable. So I've had really good success with that. So I know a lot of people fuss about this workhorse, that workhorse. feel like whatever workhorse they contract with is what I'll do, because I'm more interested in having those specialty wires. And if the workhorse, the Marvel's not going, although when it does go, I joke and call it a Marvel, because then it's a specialty wire, I'll go right to Xi'an black and very low threshold for that.
And do you work for the rest of the case on a polymer jacketed wire with a loop at the end, or do you usually exchange for a supportive wire?
Yeah, great point, and thanks for mentioning that. You're leading the witness here. So you shouldn't. All wires are dangerous. I've had perforations with regular workhorse wires, but the other wires are going to be much more dangerous. So these, polymer jacketed and whatnot are going to be more risk of distal perforations. So I will definitely switch those out as fast as I can. So I'll switch out through, via microcatheter again. So having some sort of trapping device or system is in. So once you have the distally, now then if you can't get the microcatheter down, it's either a matter of switching to an alternate microcatheter, or that's when hey, we're going to have to do a lot of lesion, modification. And usually for me, that's going to be, rotational atherectomy. And so in that case, if, I can't get anything to follow, I may start with small balloons. So, 1.5 millimeter balloon to make some space, retry with a microcatheter. If not, then I'm just going to bury my microcatheter in, take whatever wire I have out, go in with a roto wire, and roto over that, and then start the process again.
Got you. Yeah, what you just said, you glanced through a lot of little tricks. So I'm going to try to dissect that. In terms of microcatheters, give me your thought process on what microcatheter you pick for tortuous anatomy.
Yeah, so I think in general, we just start with the Mamba microcatheters. Again, that's what's on the shelf, that's what's contracted, and I've had great success. So I just go with a regular Mamba microcatheter, and that's my 90% go-to. I think, if I'm having trouble getting that down, then usually I'll pivot to like a turnpike spiral. Would be
Why is
another
that?
one. I think, it's a little lower profile, or Corsair XS Pro, same thing. They can sometimes get places a little bit better, although you're spinning. So you have the rotation, and it's important to know some devices are clockwise, some are counterclockwise. So it's important to identify that in advance. So that can help you with delivery. But I've had case where one goes and the other one doesn't, and then the other one goes and the one doesn't. But I think some of that, if something's not working, I always joke, if you're at a door that's a pull open door and you just push and it doesn't go, you push harder, you're only going to break the door. If it's you have to stop and say, what is the barrier here? And so I very quickly switch out, microcatheters. So that would usually be my switch there.
And which microcatheters you don't recommend spinning?
Again, I don't use most of the. I mean, I know the like fine cross and everything. I think those are just push catheters. Don't use those too much. Although again, that's nice because those are really low profile. So every once in a while, I will pull those out because that's a push microcatheter. But really, I just need something very fine and low profile. But yeah, I think these days I'm probably using most of the spin microcatheters, like I said, Mamba, and then Corsair XS Pro and the Turnpike Spiral. Those three are probably close to 100% of my microcatheter use.
And have you ever had to use angulated microcatheters when you're really struggling and you're not getting where you need to be?
I have. I use those way less over time. I've really pivoted more towards dual lumen microcatheters. I've had a lot of success with those, and I really favor those now.
Why is that?
I think you have a lot more directionality, because rather than just relying on the tip, 90 to supercross, 90, 120. I think having a side, the side port on the dual lumen microcatheter really gives you a lot of options. So, I have a wire down let's say if I'm going into the circumflex. So I have a wire down the LAD. I have support. I have a supportive microcatheter. I have a side port. Now I can use a second wire, which would just, typically be the Xi'an black for me, and it really gives you a lot of support and a lot of directionality, and I think that's very important. So I go to that immediately, and I really don't use the angled microcatheters anymore. And there's really a whole slew of dual lumen microcatheters and twin pass. I use the Sasuke a lot, so I think there's a lot of options on the shelf. And again, like anything else, it just takes a little getting used to. So as best you can, you talk to your company reps, and they'll have demos because you don't want to go into the body for the first time using something and not understand some of the nuances of, which port am I using? How do I get the wire in and out, and maneuverability so you don't go in and then pull all your wires. But yeah, I'm a big fan of the dual lumen microcatheters.
Yeah, I tend to agree with that. Obviously, there is a role for angulated microcatheters. The downside of that is obviously you don't have a backup wire for your main vessel, so you can always lose that while you're manipulating. And secondly, the management of the angulated microcatheter should be very regimented by having the microcatheter on the wire, pulling the wire where you think the angulation is, and then moving that. If one would kind of turn the microcatheter right and left and try to poke with the wire, you can end up obviously with going subintimal and all of that. So I feel like it's a double-edged sword. So kind of going through the microcatheters, and now let's say you had delivered your wire, your polymer jacketed wire, and you decided this anatomy, no way, I'm going to need a supportive wire. What do you exchange for?
Yeah, so I'll be honest, I usually, again, going through, my algorithms, I don't use that many, supportive wires that often. I mean, very, very rarely. So again, I'm going to get the microcatheter down, or like I said, if I can't get the microcatheter down to switch to a workhorse, then I'm going to have to, wedge in the microcatheter, deliver rotational atherectomy, floppy wire, rota, then go back, deliver the microcatheter, and then use the workhorse wire. To me, having the microcatheter, having the guide extension catheter, and I use a lot of balloon anchoring, to me, that obviates usually the need for any of the, supportive wires. I'm actually trying to think about what we have on the shelf because I haven't called for one for a while. And usually when I call for something, that's contracts change because I use it so infrequently. So I just ask what do you have? But I think that speaks to more that is not a big part of my personal algorithm because of the other equipment I use to achieve the same goal. But that may be different for someone else.
No, I love that you use mostly buddy wires and you're putting a balloon on one of them when you say anchor. And then is that what you meant by anchor balloon?
No, so usually if I'm talking about like a distal, so I'll do that in like CTOs and sometimes too, but I'm talking about a distal anchor. So if I know, if there's tortuosity, so one, lesion preparation, intracoronary imaging, know what I'm dealing with, and then also know I'm going to have to work from distal to proximal. And sometimes if you don't do that right, you're never getting back through that territory. You may only get through that territory once. So I'm talking about a distal anchor balloon. So I will take a compliant balloon distally and use that to really pull in that guide extension. Because then, again, this is presuming I've already done atherectomy prep work, but for delivering non-compliant balloons for further prep, and then I will always swallow those balloons and use that guide extension catheter again, because then for stent delivery, I'll get whatever length stent I need. I'm not going to do a bunch of short stents. If I need a 48, whatever you need, it becomes a non-issue if you have your guide extension catheter delivered distally. Now, I'm also cognizant in my mind, when you deliver a guide extension catheter distally, there's also risk of dissecting more proximally, so I have to have that in the back of my mind, be prepared to deal with that if that does in fact occur. But yeah, I'm talking specifically a distal anchor balloon on the workhorse or your working wire to get your guide extension down after you've already done your lesion preparation, after your intracoronary imaging. And then again, each time I'm putting equipment down, I'm getting that guide extension catheter back in, which also goes back to what I mentioned at the beginning about minimizing ischemic time. So I have to know that, I'll talk through my team, this is what we're going to do. And I need step 1, 2, 3, 4 ready, because if I'm going to deliver that guide extension distally into the circumflex, I'm going to create a lot of ischemia. So I need to be ready immediately to take the anchor balloon out, go in with an NC balloon, come back out. Then use that to go back in, and then go back in with the stent. So all of that should be very fast and efficient and have the equipment lined up. Everybody in my lab knows always better to put stuff away than have to go search for it, right? Every time you go out and get a piece of equipment, it's 5 minutes. It seems like an hour. Pile up the equipment more than what you'd need before and then go put it away afterwards. easier.
That's perfect. And for the early career audience and the interventional fellows listening, you obviously mentioned the balloon-assisted tracking. Give us also an idea about the two other techniques that you use to deliver. If the balloon-assisted tracking, let's say you're advancing and you felt resistance at one of the turns and you don't feel comfortable with that resistance. At this point, what do you switch to in terms of alternative techniques?
So you're talking about like radial access balloon?
Winch warming and
got it. So
and
yes,
balloon surfing. Yeah.
Okay, got it. Yeah. So it's not really balloon assisted tracking per se. So I'll use a distal anchor balloon. There's different methods. So and then I will pull the guide extension, towards that. Sometimes if that's not doable, then yes, I'll have the balloon just sticking out of the guide extension a little bit, inflate, and then during the deflation, you have to coordinate with, your tech to then advance, right? And then as you point out, inchworm. So then you advance over the balloon, gain a little bit more real estate, territory, whatever you want to say, then push the balloon further and do it again. And then you have secured your territory, and then delivery is no problem because you can get, as long as you don't have equipment that's too big for the French size, then there's no problem getting anything down.
Do you find the balloon surfing technique helpful where you inflate a balloon at the tip of the guide extension at a low 2 atmospheres and you actually advance both of them as a unit, like a dilator kind of analogy, into a tortuous segment with calcified nodules that the other two techniques are not getting you through?
Yeah, I really don't use that. So again, it's hard to comment. And again, it goes back to, there's a lot of similarities and nuance, and I think there's a little nitpicky, and so it's whatever works for you. Clearly, right. I would say that's not an essential technique for me because I barely ever use it, and I still get the job done, but that's going to look different for everyone. And again, this is where you're talking about all stuff within the same bell curve, where 10 of us can be right, doing things a little bit differently, because frankly, the principles are exactly the same. So some of those little details, rather than getting hung up on it, I think we have to remember that we're actually all talking about the exact same principle of distal equipment delivery, doing it safe, utilizing the balloon, using guide extension catheters, and not get too hung up on, the little nuances, or someone will call it the Hady technique, the Alex technique, or whatever, right?
Right. Great. So in terms of balloons, you mentioned balloons, obviously the smaller, the more deliverable. Do you have any special brand balloon that you think is more crossable? Let's say you're having a hard time crossing with anything else. Anything specifically you pull out as your last resort?
So I think the only thing specifically that I've used, and again, started using this more in the CTO space, is a 1.5 to Caru. So if something's really hard to cross, that'll now be my, go-to. Once I've made space with a 1.5, I kind of don't care whatever company. I'll just say, hey, give me a 2.0, give me a 2.5, whatever you have on the shelf. And I will say this is also a practical issue. When you're contracting with, we're a busy center. We have everything on the shelf, right? But money still matters. And so if I'm going to tell administration, I want this, that, or the other, and then my partner is going to say, I want this, that, or the other, we all want our special thing, we're going to screw ourselves, right? Cut your nose to spite your face. So workhorse wire, whatever you want. If you save money on a workhorse wire, fine. You give me whatever workhorse wire, but then I want a specialty wire, these ones. And I only want different categories, and I will show you that I'm using them the right way. Same thing. I don't need 100 microcatheters. We as a group have to decide what are our top 3, and maybe we have, a 4th on the shelf. So same thing. If you tell me that contractually Takeru is more expensive, then I won't use that for every lesion. But I will demand and really push that we have, certain sizes on the shelf for when that's the only thing that can get the job done. So from a strategic standpoint, I will really push administration and push the financial piece, but I will also show that I'm being a good steward and we're meeting in the middle. And I think that's a good approach. So like I said, I've had great experience where nothing else will go. For the 1.5 and after that, whatever's on the shelf, I feel like once you've made space is usually pretty good.
I love the fact that you're bringing up the business of medicine, the negotiation, the alternate level of interventional cardiology, where you have to kind of factor in so many other decisions, business position, cost decisions, in order to do what you need to do. So these are fantastic, and I love that. Now, just forgive me for kind of rewinding a little bit. We only skipped the right coronary artery when we were talking about guides. I'd love for you to tell us what you use, and then we'll move on to the imaging catheters for tortuosity.
So for diagnostic, I don't use universal catheters, so I'm a JL JR. So first of all, from the diagnostic films, then you use that information. If it's something straightforward, I'm just going to use a JR4 guide. But for something not straightforward, I'm a big fan of the hockey stick. So I use that a lot. And we use that for a lot of our CTOs. And then otherwise an AL 0.75. So those are usually the, two probably more hockey stick than AL 0.75, but that AL 0.75 can really get you there as well. So it then can give you problems if it's an osteal lesion afterwards to manage it afterwards. But again, this is part of knowing those things, knowing those guides. But those are those 3 guides are 99% what I'm doing in the right coronary artery.
Excellent. So now you want to image. You were able to get a tiny balloon through. You want to have an idea before you make a decision about atherectomy, IVL versus not. What imaging catheters are you favoring in tortuous segments? Yeah,
so I say first thing is just image. The second thing is just image. Third thing is just image. So, where we were and probably where I am and probably where most places are in the US, when you're fighting about, well, I want this catheter, I want that. I just wanted something on the shelf. And I wanted to plug in the lab because I did not want to create barriers for other physician colleagues who, if you put up the smallest speed bump, they're not going to image. So it has to be the easy button. So I'll even go back and say, I do a diagnostic angiogram. The first thing I do is I call for heparin and I set the timer. I'm not going to check an ACT for 5 minutes. By doing that sequence, now I have 5 minutes to set everything up. So I give that instruction, timer starts, then I ask for the guide. Then they set up IVUS, and it's all automatic. So now, by the time I'm checking my ACT, everything's ready. IVUS is set up. So again, talking about case flow, that's an important step. We have the Boston HD IVUS, which I love. And, if that doesn't deliver, then I got to use lesion prep, right? I mean, then I know I'm going right towards rota, but usually you can wedge it in enough to at least get some basic view. So that's what we're using in our lab. I know a lot of people use other systems, and I think all of us, you're probably happy with whatever system you have. I will only say that I don't think the non-HD IVUS, I just don't think they're up to par these days. I think if you don't have a sled or some other measuring capability, then I think what you're doing, in my opinion, is what I would call performative IVUS. Shove it in, pull it out, say I did IVUS, but you might as well have your eyes closed. You might as well, I don't know why you're doing it. You're not really providing advantage. So you have to do it. You have to know how to interpret. Data has to be actionable data. But yeah, I really like the Boston HD IVUS. I find it, deliverable. If it doesn't deliver, I know I got to do lesion prep, and then using that to guide, next steps.
And between 5 French and 6 French Boston, which one would you pick more for tortuous segments?
So I pushed our lab years ago to go completely to the 5 French, and only because when it first rolled out, there was equipment compatibility with some of the guide extensions and other things. And again, my focus was people aren't doing IVUS. I want to remove any barriers. So a barrier is if you have to get the wheelie cart, so put it everything in the lab. If you have to go get the box, so put it in the lab. If you have an experience where they don't deliver and you're already not interested in doing imaging, you're not going to do it again. So, and again, from contracting and supply, fewer things on the shelf, streamlined, because those are other realities about the day-to-day operations of a cath lab. 5 French. So now we have both on the shelf, and sometimes, supply is low on the 5, we'll get 6 replacements. So it's probably less of an issue, but we started out just to have one common thing. We used the 5 French, and I never had any issue with that. Again, to me, if something's not delivering, it's not necessarily the device, it's you haven't paved the way.
Yeah, one personal note transitioning from non-HD IVUS to HD IVUS, I found using the 5 French, obviously there's a price to pay from a technical standpoint for having such a deliverable, flexible catheter, which is kinkability. When you're advancing, I noticed that I had to really use super short strides, like almost 1 to 2 centimeter strides advancing the catheter in the guide. And that sometimes made it difficult for me to deliver a 5 French versus a 6 French. There's 6 French version. If you have a big enough lumen, I found it's personally my favorite because the shaft of the IVUS is a little bit more pushable, but obviously very technical, and you can do it both ways.
No, that's very true, and you're totally right. I think it is easier, and again, some of this goes back to that, like I said before, that balance of how you think through all of it and what can you get on the shelf, and then some of it, like I said, I've been using the 5 French for so long that I'm just used to it. But you're right, you have to be intentional and careful about it. But I guess now, like, my brain hand connection is probably set where I don't have those issues. But right, I think anytime you're switching from something new to something new, there may be some nuances where you probably have to adjust and be deliberate. And so that's a great point.
You have OCT in your lab?
We do. I haven't used it that much, frankly. And again, it's not for any other reason than I fought so hard to get IVUS. I fought so hard to get HD IVUS. I almost didn't want to push for something else because you got to figure out, I make enough fights, like, you got to be careful. But also, I feel like now I really know what I'm seeing on IVUS. And so we're bringing in OCT, and I think relying on my colleagues and relying on industry, because I have to be taught, because if I don't know what I'm looking at, then that's a problem for me. And so,
and deliverability, do you feel like it's a promising catheter, OCT, Dragonfly?
So again, I don't have enough experience to be able to give an opinion.
So now you decided you're going to be using atherectomy for this case. You have met your criteria on imaging, and you have a very tortuous mid-right coronary. So what goes in your head about avoiding complications, and what would you pick?
Yeah, so again, this comes down to you have to know yourself, know your comfort level, and you and I have talked about this before. I love the movie Ronin with Robert De Niro, right? And there's a lot of great lines, but one of the lines, and I'm paraphrasing a little bit, is like, never walk into a room you can't walk out of, right? And that's for both you and the patient. So it's not that there's no-go tortuosity or there's no-go anatomy. You just have to look at the risks and benefits. You can have no discussion about risk without a discussion of benefit, no discussion about benefit without risk, whether that's pre-procedure with the patient, whether that's within the cath lab. And then there's your comfort level. So I feel pretty comfortable with ROTA, just regardless of the tortuosity. So that's going to be my go-to, and that probably won't dissuade me too much. But if there's an anatomy that really is giving me pause, then yeah, let me go through and try some NC balloons first, deliver a guide extension catheter. Maybe I'll go right to, IVL if that's something that's going to be deliverable through a guide extension there. But like you said, I feel pretty comfortable with ROTA. I don't use orbital really much at all. And it's not because I think one is better than the other. I just use ROTA, and that's what I'm comfortable with. And I think it gets the job done. I have partners who say the exact same thing about orbital atherectomy, and we probably think it's better. I think they're probably the same. It's just, what are you trying to achieve? Because, as I tell my patients, I'm just trying to create pleats on a skirt. I'm just trying to break up the calcium so that then I can expand, with a balloon, so I can deliver my equipment and get good, final on, minimal stent area.
Yeah, I love that both companies found solutions for tortuosity. I mean, obviously, Boston Roto is front cutting, so it's perfect for really getting through a lesion as long as it's not really an acute bend with perforation. But the glide assist option of CSI is really effective. You can cross with it and then burr on your way back. And I found this to be very helpful in certain anatomies. And it's a very kind of operator dependent, but I feel like we have a lot of options and really blessed in that way. Now, in terms of laser atherectomy, do you feel like this has an advantage in crossability over the two other ones? I'm not talking about severe calcium. Let's say you have a moderate calcified lesion, an acute MI with a thrombotic component. Do you pick laser?
Yeah, I know some people do that to, ablate the thrombus and intentionally. And again, if that's part of your workflow, that's fine. For me, the laser, when I've used it, is again been for those, uncrossable lesions where I can't get a balloon across, I can't get a microcatheter across, and maybe there was something anatomically about it where I was worried about the ability to wedge in a microcatheter and deliver, just free deliver a rotowire. So I've definitely used laser in those instances. Also used it for ISR. I think it has a really good application there. But for crossability, yeah, I think that's where I've used it, where I'm just trying to create a pilot channel. But I probably more often wedge in a microcatheter, deliver a rotowire and just a rota. But I think either or. I've used both of those for the same purpose.
And let's say your imaging data kind of gave you the option of using IVL and you picked it. Do you use IVL if you can deliver the guide extension into a tortuous segment? Do you even try?
Yeah, so if I can't get the guide extension, in my opinion, I'm not going to get the IVL. So I think, if you can get the NC balloon down and get your guide extension down, then you can probably get IVL. If not, then you need to do something before. And I think, again, this goes back to there is no device that does it all. So, I used to do a lot of rota and cutting balloon, right? So now it's rota IVL, because if I get the pilot channel, score that calcium, create, a passageway to then IVL. If I have like a 3-5-4-0 vessel, then the rota and probably NC balloons are probably not going to do enough. But again, this is where you really have to rely on your imaging for what's your arc of calcium, what's your thickness of calcium, what's the length of calcium. So that all has to go into play. And if you're always making a decision saying, well, I'm not going to use IVL because it's more expensive, or I am going to use it because it's covered, that's not the right way to look at it. Again, the economics, what's the economics of someone an hour on the table? What's an economics of a perforation? What's the economics of someone being in the ICU for a week? What's the economics of death? So these are all things I bring up when people tell me it's more expensive. I think as long as you're using your data, your angiographic data, your imaging data, you're meeting your endpoints, then I think it's really hard to argue. Now, clearly, if you're pulling out all these devices when there's no calcium or very minimal calcium, then that's obvious. But if this is data-driven, I think there's a lot of ways to, skin this cat.
Excellent. I found personally that with IVL, this wiggle wire has helped me so much. And of course, it's one of those, million choices you can pick. But when I crossed with a polymer jacket, I exchanged for that. And then obviously the pulling of the wiggle wire allows that to kind of dodge a few calcified nodules. And I found that this is really helpful. So now at this point, you're atherectomized or you used IVL. We're getting to the stenting part. It's a 40 millimeter lesion through 3 turns. Are you going to pick first of all, what kind of stents do you favor? Do you have any flexible stents that you like over others in these anatomies?
So I'm in private practice. So I now work out of 4 cath labs. I'm like 90% in one cath lab, but from time to time I'll work in the other. But that used to be 5 labs. And those were across 3 different health systems with different contracting. So it was sort of you get what you get and you don't get upset. So I would use all the stents. So whatever they tell me contractually to use. I haven't been able to notice a difference in deliverability and anything else, which again says to me, that's not where I'm going to fight about. If you're contracted for one stent versus the other, fine. I want to worry about atherectomy, things to deliver, those guide extensions. I think if you prep the lesion and you deliver things, to me, it's been my experience, I could close my eyes and it doesn't matter what stent someone's giving me. Again, I know people have favorites. I haven't found that to be real, the Achilles heel of anything in my experience. Contractually, the place I work the most, I'm primarily using a Synergy, and I've been very happy with that. And then people say, Resolute delivers better or Xience delivers better. I said, I wouldn't know because Synergy seems to deliver all the time. And again, my gut feeling, I'm clearly opinionated, as you can tell, but my gut feeling, it's more about the lesion preparation than the actual stent. I mean, these stents are all, you're splitting hairs with the technology is so good these days.
Absolutely agree. Now, would you pick shorter stents, or you go for the longer stent first, and if that doesn't cross, you start kind of dividing up that lesion length?
I would always go for the longer stent. So to me, again, image, measure, prep the lesion, re-image, deliver the guide extension catheter. And again, realizing that I don't want to cross territory multiple times that I don't have to. And especially if there's a lot of tortuosity, every time I deliver small stents, I'm creating multiple new points of failure, multiple new points of hazard, multiple new points where it'd be difficult to redeliver equipment. I would much rather have one long 48 millimeter or whatever, 38, 48 millimeter stent to cover that whole territory. And then when I inflate the stent, I will bring in the guide extension catheter as the balloon is deflating. I'll take my NC balloon, so it's coming in protected, no deliverability issues because I have a guide extension catheter, do the NC balloon, swallow that balloon again to get the guide extension catheter back, get my imaging catheter down while staying somewhat within the proximal edge of the stent. And then if I need to do anything else, I still have that real estate. Once you come in and out, if your stent's delivered on an angle or it's not fully, expanded, this is when you start accordioning your stent. You get the longitudinal stent deformation. And I'm not saying I've never done that, but every time you just added a half hour, 45 minutes, an hour to case, and you took something that could have been a lot easier. So to me, I always go longer.
These are extremely helpful tips. Do you feel comfortable crossing an entire lesion with a guide extension and unsheathing it with a stent?
Again, I'm an aggressive operator, and everybody has a different threshold. I feel comfortable, but I've gotten them into every distal vessel, every mid vessel before, and I have a very low threshold. Have I? Very rarely. But yes, have I dissected an ostial or left main doing that? Yes. But I've also seen, being on QA committee and other things where a lot worse things happen. So I'm not saying it's not without hazard, but again, if you're imaging, you're measuring, you're doing it carefully, I do it all the time, and that's my go-to.
And do you factor in one thing I haven't asked you about the guide extensions, the size of the guide extension? If you are thinking from the beginning of the case, you're going to deliver that into a PDA, do you pick a 5.5 and a 7 French guide? Do you pick a 5 or a 6 French?
I never put it in the PDA. I'd like to, the more distal you get in coronaries, the less I'm concerned. Like I talk to patients, I don't know what the highways or freeways are in your area, but here when I talk to patients, I'm like, we're working on this 8-lane highway, this 5-lane one. I don't care about your side street, your cul-de-sac, the little boulevard. So mostly if we're talking about guide extension delivery, it's typically up to the mid or the junction of the mid to distal vessel to deliver equipment. But yes, good point. For proximal work, and I want to have a lot of equipment, so maybe I'll use an 8 French guide extension. Or now, I think so much has been miniaturized. Most of the time, it's 7 French and a 7 French guide extension. But if I do need to deliver distally, and it's been a lot of tortuous anatomy, and it's a smaller diameter vessel, then yes, I will switch out. So yes, sometimes I'll then end up using 2 different guide extensions in one case, and I'll switch from a 7 down to a 6 precisely for your purpose. We do have the 5.5 guideliner on the shelf too, but again, some of it is just contracting. I think the 6 French Guidezilla is what I mostly use, is usually enough, but that 7 to 6 transition difference is important. It's a good point, and I definitely will do that.
Excellent. And I've seen people, obviously, at different cultures of how to cross with a stent. Let's say you've atherectomized, you prepped, and despite that, you're still having a hard time delivering your stent. Would you prefer a slow and steady push on the stent delivery rod, or do you like to daughter that back and forth, or a combination of both?
I'm laughing because I'm an aggressive operator. So any equipment I've touched, the joke is that it has the MOB, the mark of the beast on it. So all the delivery devices are bent and mangled. That's just I guess I'm the beast, and when other colleagues are the beauty. So yeah, I will shove those things. But again, to me, it's more about having the guide extension down, because then that usually obviates anything that you're talking about, because then you have a smooth path. You have a smooth path through the guide. You have a smooth path through the guide extension. And so you don't have to do that much of that other pushing, which then avoids those other risks of stent stripping, of not being able to deliver, of getting a stent wedged in where you don't want, and now having to deliver something even more distally, which will be even harder than what you started with. And now you've made a hard case into a hard case.
That's right. Absolutely. I found with the more I use guide extensions, the less independent hand technique and all the using the guide with your left hand and the stent delivery with one hand are not really necessary anymore. But once a year or something, we have to do that. Now, just one word on the pseudo lesions. While you're working, of course, you're causing ischemia. You said you don't like super supportive wires partly for that reason. But if you do have pseudo lesions and ischemic time, would you pass a guide extension safely through a pseudo lesion, get the job done quickly, and disengage?
Oh, yeah. Like I said, a pseudo lesion is just that. It's a pseudo lesion, so I don't really care. And again, whatever, you got to do what you got to do. So if I need to treat a mid lesion and I need to deliver equipment distally, part of that, again, is I'll go back to what I said in the beginning, is prepping up front. So picking a good guide that I'm not going to be backing the guide out over and over. I'm not going to have to switch guides. I'm not going to have to futz around. When do I have to prep? Once I have my anchor balloon, get the guide extension down. Have already imaged. Have all the NC balloons, have the stents ready to go, so that I don't have that deep-seated for longer than I need to. And every time I pull it out, realizing could get a balloon back to re-engage each time. And then for final angiography, I'll pull the wire out, have it still sitting a little bit in the vessel through the guide, but to make sure. And then again, also, other things that we should mention, giving intracoronary nitro. So I think that's essential. That's essential in diagnostic angiography. I think we've all seen people get unnecessary stents, get unnecessary bypass. So I'll make that point, but also certainly during intervention as well. And then the last thing, because you brought up something that I've been guilty of and we're all guilty of, is wire control. So watching that distal wire, because when you're doing, one of the hardest things I think in training and in practice is to negotiate that push-pull. Right? Equal and opposite forces. So if you're pushing something, something else is pulling. If you're pulling something, someone else is pushing. So is your guide going to jump in? Is your wire going to jump out? And those are, risks where you have to get that hand-brain connection and visual, what you're looking at the screen, what you're feeling, and just be very diligent. And I won't pretend for a second that I'm 100% successful, but the more deliberate you are and you're aware of that as a hazard, the better you'll be to prevent it.
So to conclude, on the way out, now you did a fantastic job like usual, and you're on your way out. You went radial. You had a hard time crossing a radial tortuosity. Do you just give a puff in the radial on your way back, or if the patient's asymptomatic, just go for the hemostatic bend?
Yeah, I don't. So I think if you went in radial, like I said, if you went in too aggressively on the way in, a patient's going to let you know on the way in, and then you have to decide. Usually you're going to do an internal tamponade if you switch to a coronary wire, all the things we talked about in the beginning, and then you have the guide in throughout the case. That's going to tamponade any injury you had up front. I think at the end of the case, if that happened, it's done. If that didn't happen, nothing's ever 0%. But it would be really, really unusual to have trauma coming out. So I think that would be a very low frequency event. But it does bring up another point, is that, I know we break scrub, you go out and you write your report. It's always good to walk back in and look at the patient before they leave the room, because that's usually a 10-minute process, gives you a 10-minute relook about the wrist, the forearm, the groin. And then also make sure in your recovery area that you're training whoever that is. Is it APPs? Is it nurses? Is it techs? It may be different, so that people can recognize some of those complications. If you have swelling forearm, impending compartment syndrome, and what the steps are to solve that. But that's a pretty I haven't seen that in years. And then again, I think if that's going to happen, you're going to know it at the beginning of the case, decide to push on anyhow, and then you'll be thinking about it at the end. I can't really think of too many ways it would happen spontaneously at the end.
And then finally, tortuous iliac, you want to close, you used an 8 French or a 7 French. Do you have any preferences in closure devices?
I use a per-close 100%. Again, I think some of that's just muscle memory. I'm used to it. I'm comfortable with it. I pre-close all MCS, whether it's leave-in or coming out at the case. Anything else that's just, 8 French, I'll just do standard post-close, per-close. I think, if you're worried about tortuosity there and you know about it, it's a flexible, tip. So that's where I will observe under fluoro. And so, observe the wire going up, and maybe then I will switch to a stiff angled glide wire to get up, or I'm just going to be more intentional about that going up because you don't want to do a good job and then dissect with your wire exchanges. I always use a femoral length 035 wire for my per-close. I don't use the little short sheath wires. I just like having the extra length. But yeah, I always per-close. And the one slight modification that I've now encountered, because we just got Rampart into our labs, which I think is fantastic. But so it's brand new to me. And so what I've been doing is for a femoral access, I'm wearing the lead, getting the access, and then taking the lead off and moving it back in. And sometimes similarly for closure, just because I haven't quite figured out my workflow yet, where it's a little bit cumbersome with the drape sitting over that and the x-ray coming back and forth. But that's again where I'm going to reach out to other people and say, what do you do? What do people do? Because we all got to learn from each other. But that would be the only modification now with our Rampart cases, which is like 2 weeks in for me.
No, I'm glad that you don't have trouble delivering a per-close through tortuous segments, and the fact that you're using a 45 centimeter sheath, usually you don't have to have an extra short sheath, so that also saves some time. Well, this was a fantastic discussion, a little bit more than an hour, but I definitely think this is the bread and butter for what interventional cardiology is all about these days. It's rare to find straight segments, looks like, in the coronaries. And thank you for all these beautiful tips. And any final words, Alex, especially for the mid-career busy chip operators?
Yeah, I will say, so I think if you're in training, just master the fundamentals. I think if you're in practice, realize my experience is if you are not altering fundamentally your practice 50% every 5 years, you're way behind. Now, that can be either an exciting proposition over the course of a career, or it can be scary. But I think it's, regardless of whether that's exciting or scary to you, it's a fact. And you owe it to your patients. So there's new equipment, there's new techniques. You can't just live in your own bubble, in your own lab. You have to look around what else is happening, be humble, learn from other people, grow, figure out what other people do. I steal, better ideas all the time. And I'm constantly evolving my practice. And again, where our patients are getting older, sicker, more comorbidities, more complex lesions, our work is only getting harder, but we can continue to do it well or even better if we keep getting better. And so that's probably the biggest thing I'll leave with, is that it is a day-to-day battle and journey to get better. And if you don't, you will be behind faster than you know. And then it's too late for you and your patients, frankly.
Fantastic. We'll close on these words of wisdom, growth mindset, and hope to see you all and get you all back on the next episode. Have a good day.
Thanks, Hady.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTable Cards
on Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hady Lichaa
and Sami Seifo.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.